Now which antibody you see in myositis? We have what is called as the anti-Jovan antibody, which is typically found in the case of dermatopolymyositis is what you need to remember. So anyway, in rheumatology we will have a review on this. Now there is one more thing called anti-signal recognition particle antibody. Signal recognition particle is important in the protein synthesis, and antibody against that will lead to development of the typical atrophy of the muscles is what we need to appreciate. What are the causes for the spontaneous CSF leak? Basically, when the CSF is leaking, very commonly it is due to trauma. In some people without the history of trauma, there can be a spontaneous leakage, more commonly in the middle-aged women, and if you evaluate, they will have a small encephalocele which will be responsible for this leak. Similarly, there is an entity called benign intracranial hypertension. Even in this entity also there can be a spontaneous CSF fistula developing, and very commonly this spontaneous CSF fistula develops into which structure? Into ethmoid and cribriform plate is what we need to appreciate. So there is a reason low risk encephalocele, pseudotumor cerebri and empty cellular syndrome. They are known to be associated with a spontaneous CSF leak. Now comes the favorite aneurysm compression question. So May 2008 of AIMS. Which nerve is compressed by the posterior communicating artery? You are all now masters, oculomotor nerve. If a non-noxious, non-painful stimulus is perceived as a pain, what is the cause? It is also called as allodynia. Mainly you need to know a little terminology. Paresthesia means that pins and needles. Dysesthesia means any abnormal sensation including painful, painless. Hyperesthesia is increased sensitivity. That's what we need to identify. Then once more, May 2008, the secondary structure of the prion protein in the prion disease of the Creutzfeldt-Jakob basically has which biochemistry में alpha, helix, beta, pleated sheet वो सब पढ़ के भूल गए ना? Which structure does it resemble? But before that you should know what is a prion protein and what is this prion protein SC, PRPSC, what is it? So fundamentally we have what are called as the human prion related proteins, doctor. They have got a alpha helical structure. They are produced within our own body in the host only, and they are produced by the activity of a particular gene called as PRP gene. अगर PRP gene normally काम कर रहे और PRP protein तैयार हो रहे, कुछ भी नहीं होगा. They are all normal. But suddenly if there is a mutation in this PRP gene, then what will happen? The PRP protein which is being produced is a one which is incorrectly folded, and that lead to what is called as PRPSC protein. Unlike the PRP protein which has got a alpha helical structure, PRPSC protein has got a beta pleated structure. Then what will this PRPSC protein will then be doing? It will be interacting with every PRP protein और उसको भी खराब करते रहे बैठेगा. Then finally there is an accumulation of a lot of PRPSC proteins, and they in turn will form aggregates, they become plaques, they will destroy the nervous system, and finally it lead to a huge disease. So it is not due to infection, it is due to wrong unfolding is what we need to fundamentally appreciate. So PRP is alpha helix, but PRPSC is basically beta pleated sheet is what we need to understand. There is a painful ophthalmoplegia, cavernous sinus dilatation. Then what is the most likely diagnosis in this patient? Now we are going to have few words about cavernous sinus anatomy and then differential diagnosis between one and the other. What is cavernous sinus? It is a venous sinusoid. It is there on the either side of the pituitary, and there are a lot of afferents into it, and some channels will drain out of it. It is very important because a lot of neurological structures will be passing. It's like a coastal belt. Coastal belt. Orissa, West Bengal kind of a belt. It's a samundar. So on this you have a lot of islands. What are they? Oculomotor nerve, trochlear nerve, ophthalmic division of the fifth cranial nerve, maxillary division of the fifth cranial nerve, abducens. These are all there. So any of these structures can typically get involved once there is any thrombus or any aneurysm within this cavernous sinus. Similarly, you also have the sympathetic fibers which are passing through it. That's the reason it can lead to Horner syndrome, cavernous sinus pathology. Now, this patient who is being given to us is having a painful ophthalmoplegia and enlargement of cavernous sinus. They are the two important clues that we are having. Now, let us assume that possibly this is a case of cavernous sinus thrombosis. Why it can't be? Or why it can be? In cavernous sinus thrombosis, patient will have a painful ophthalmoplegia. That's true. And the CT scan, if you do, typically around the pituitary you have the cavernous sinus, no, it will show the presence of a clot. So that is the reason what you have is a thrombosed vessel but not an enlargement of the cavernous sinus in case of the cavernous sinus thrombosis. So it is unlikely. Then can it be orbital pseudotumor? What is this? Basically there is a mass on the cone of the extraocular muscles. You have that superior oblique, inferior oblique, all they form a cone, no? There. And in this cavernous sinus won't involve at all. But why did we thought about it? Because even this can lead to proptosis. Cavernous sinus thrombosis can lead to proptosis. Due to the proptosis we thought of it, but there is no cavernous sinus involvement as such. And ophthalmoplegia is not a feature in this. Can it be Gradinigos syndrome? In Gradinigos syndrome, there's a petrositis, otitis media, retrobulbar or facial pain will be there, and sixth nerve palsy. Because of that, abducens is gone, medial deviation is there. Then, but that is not the scenario here. Can it be Tolosa-Hunt syndrome? What is Tolosa-Hunt? There is a granulation around the cavernous sinus and carotid artery due to the chronic inflammation, and here the cavernous sinus, as what you can see, become enlarged, and this presents with a painful acute ophthalmoplegia. Hence the diagnosis becomes classically a case of Tolosa-Hunt syndrome is the answer. So the presence of ophthalmoplegia, involvement of oculomotor or trochlear or any of these structures in vicinity of cavernous sinus, and a very rapid response to the steroid treatment and the recurring attacks, and on CT enlargement of cavernous sinus, they all constitute the important criteria. Then AIMS May 2008, you have a question on Lermits-Duclos disease is what? It will never come in exam, future exam, but sometimes examiner will be fighting with a sword, suddenly he will take a gun and fire. So don't be scared about those bullets, because everybody suffer it. But if you wasted one day full time on Lermits-Duclos, then definitely you are suffering from which psychiatric diagnosis? OCD, obsession to learn everything perfectly, which is not required. But anyway, I suffer it. Look, the Lermits-Duclos disease is because of what? The cerebellar fovea. See doctor, how do you recognize cerebellum always? By the folia, leaf-like structure. How do you identify cerebellar degeneration or agenesis? The prominence of the folia. Prominence of the folia. And prominence of folia can also be seen in this Lermits-Duclos disease, that's all. Now, with regard to the autonomic neuropathy, how do you diagnose autonomic neuropathy? This is a very important question. Why? Because you'll have diabetic patients. After a period of time, one of the end complications is autonomic neuropathy. You should know how to diagnose autonomic neuropathy, at least in your diabetic patient. That's the reason. The resting heart rate of 100 beats per minute or more, that is called resting tachycardia. If it is there, it is autonomic dysfunction. And lack of beat to beat variability on ECG. And you will basically ask the patient to do Bell-Selva maneuver, and you will be calculating the shortest RR interval and the longest RR interval. If the ratio is 1:1.10 and more. And ask the patient to stand up and then record the ECG for 1 minute. Measure the shortest RR interval around the 15th beat after standing, and the longest interval after the 30th beat, and the ratio between the two, 30 to 15th beat ratio. That is also a criteria if it is more than 1. More than 1 is criteria. If it is less than 1 is basically abnormal. So I leave to you ECG criteria, resting tachycardia. What is the way by which we can diagnose the autonomic neuropathy? You should be very sure. If a patient with autonomic neuropathy happen to have a MI, typically it will be a painless MI is what you need to basically appreciate. So if you look at clinical features, patient can have hypertension, resting tachycardia, early satiety, lack of sweating, gastroparesis, etc., etc. Any of them can be the problems. So Millett-Gubler, where do you have? So this table you should not forget. 3rd, 4th, midbrain, 5, 6, 7, 8 pons, 9, 10, everything is in medulla. Now, if you take the Millett-Gubler, it is a ventral pons. And pons is the place where you have facial nucleus, so ipsilateral facial palsy will be there. And lateral rectus palsy because of the abducens, 6th, which is also there in pons. And contralateral hemiplegia, why? Because through the pons it is passing, but at medulla level it will go to the opposite side. Hence, yahan interruption ho gaye to opposite side mein hemiplegia will be there. So this is how facial involvement, abducens involvement along with the hemiplegia. So NEET exam 2013, 14, 15 will be a illustration like this and ask to identify possibly which area of the brainstem is the lesion located. Now Alzheimer's, what are the lobes which are involved? Basically in Alzheimer's you have got a cerebral atrophy, neuronal loss, amyloid plaques and neurofibrillary tangles. It is a medial temporal lobe, basal temporal cortex. They are the ones which typically show the lesion. Most commonly, most severe will be in medial temporal lobe. Why medial temporal lobe is important? Because all our limbic system, Pepys circuit, have you heard it in physiology? Na? So that is basically involved. And one thing about Alzheimer's is the primary motor cortex or somatosensory association areas are visual and auditory cortices. They are spared in Alzheimer's disease. Now what happens if there is a damage to the categorical hemisphere? So doctor, dominant, non-dominant we spoke now earlier, same story. The right hemisphere is called representational hemisphere, left hemisphere in a right-handed person is called categorical hemisphere. Why it's called representational hemisphere? Because our visuospatial orientation to the world. मिरर को मिरर के जगह, अलमीरा को अलमीरा के जगह, सोफा को सोफा के जगह रखना is visuospatial abilities, is all right hemisphere. Analyzing non-verbal information. Before somebody says I love you only if you understood that they are in love with you. Non-verbal, unless your right brain is very good, you can't. And if you are a very talkative fellow with a wonderful left brain, even if the other person says I hate you, you will be thinking it as a compliment. Because non-verbal kaise bhi pata nahi chalega, verbal ko sunne ke liye already you are having verbal diarrhea. So you are not listening whether the other person is liking you or disliking you. So that's a problem. Communicating emotion also is much easier for a right hemisphere fellows, non-dominant hemisphere. So that is the reason they know how to perceive others like them or not, and they know how well to express that they too like. Whereas left hemisphere fellows, they keep on writing long stories without knowing whether the other person is non-verbally liking or not. That's a problem with the left hemisphere. So what is the general rule of life? If you love somebody, don't tell, show it. If you hate somebody, don't show, tell it. So unless you have a problem with your representational and categorical hemisphere. Now, each lobe, what are the functions? Final year MBBS paper may, one question is definitely, medicine may, lobar function you must know. Behavior, abstract thinking, problem solving, intellect, reflection, judgment, initiative, inhibition, everything is frontal lobe. Hence if frontal lobe had a problem, people will show disinhibition, leaving the clothes they run in the street. They have a difficulty in judgment, and they typically become loss of emotion. So these are all the problems. Also the sense of smell, our eye movement, gaze, and libido, most important. They're all frontal lobe dependent. Then occipital lobe, dekhna or padna, vision and reading is its function. Then parietal lobe, very important. Appreciation the form by touch is the function of parietal lobe. That's the reason what happens in Gutsman syndrome, there is a loss of stereognosis due to the parietal lobe dysfunction. Blelin syndrome, Gutsman syndrome, you have already had a review of them I believe. Then proprioception, then visual functions, they're all parietal lobe. Temporal lobe, all our memory, music, fear, language, speech, and sense of identity. मैं इस देश के वासी हूँ, जहाँ मैं रहूँ वो बड़ा देश है. So you go to America, you will wear the American jeans only. So sense of identity is also temporal lobe. What is the drug of choice and absence seizures? So each of the seizure type and the drug of choice, 100% you should be sure without doubt, doctor. Phenytoin, carbamazepine, tonic-clonic, myoclonic is valproate, absence is valproate, and any unclassified seizures also valproate is a broad spectrum anti-epileptic. For migraine management, once more the question of All India 2011. Any number of years you go for entrance, topics are same, issues are same. If you know them, you will top the entrance, doctor. But all 19 subjects you must know, 1200 topics and the issues related to that. Ek bar 30 weeks mein you need to touch everything and then go for exam. So many times we discussed, many times it appeared. Beta blockers like propranolol, tricyclics like nortriptyline, anticonvulsants can be used in the preventive treatment of migraine. Which anticonvulsants? Topiramate, valproate, gabapentin, etc., etc. Anterior choroidal artery syndrome, question of All India 2011, what are the features that you come across? First, where is anterior choroidal artery? You know very well that internal carotid does not give away any branches in the neck. Baad mein it will give rise to ophthalmic artery, anterior cerebral artery, middle cerebral artery, anterior choroidal artery, posterior communicating artery. So, you must know the branches of the internal carotid. Then this anterior choroidal artery, internal capsule is, you know, no? Internal capsule is the area through which all your pyramidal fibers are passing down. So, isko ek posterior limb, anterior limb, genu, already neuroanatomy you are sure. So anterior choroidal artery basically supplies the posterior limb, not the anterior limb of the internal capsule. And it leads to contralateral hemiplegia, hemianesthesia, and homonymous hemianopia are the features of the anterior choroidal artery syndrome is what need to be remembered. Now with regard to the posterior cerebral artery infarct, what structures are supplied by posterior cerebral artery? Basically, the frontal lobe and the anterior cortex, it is not posterior cerebral artery. I think you know, middle cerebral artery infarct mein what will you have? Hemiplegia, dysphagia, dysarthria, everything. Posterior cerebral artery involvement mein vertigo, tinnitus, vomiting, all these problems, balance problems will be there. Anterocerebral artery involvement mein what will you have? Anterocerebral artery involvement mein peculiarly, you should never forget, only one lower limb monoparesis will be there. A person who is all very well, absolutely normal, suddenly will start having a dragging leg. Monoparesis, weakness of only one lower limb, not two. Why? Because if you remember that homunculus diagram, which areas of the brain supply what? Thumb will have very big representation. In that, the lower limb passes through the anterior cerebral cortex, which is supplied by anterocerebral artery. So because of this monoparesis, the patient will be elderly person with a monoparesis. Common reason, what will you suspect, doctor? Fractured neck of the femur. Very commonly, these people poorly, they land in orthopedician's hand. Orthopedician will be thinking hip replacement is better or knee replacement, total replacement is better. Then suddenly a physician will be walking to see some other patient and say, what is the problem on this bed? See, he is unable to move his lower limb, पूरा x-ray पूरा निकाले तो कुछ भी नहीं दिख रहे, femur के जगह में है, head के जगह में है, कहीं भी fracture नहीं दिख रहे. Shall I open, fracture it and repair is what I am thinking, orthopedician will tell. Oh no brother, don't do that, you will do a Babinski. Typically anterocerebral artery territory and monoparesis. What kind of paralysis it is? UMN or LMN? UMN kind of a weakness, hence Babinski will be positive. Reflexes are hyperreflexic. No, how is it possible? Hemiplegia होना है, नहीं तो vomiting होना है, खाली एक limb का paralysis कैसे हो सकता? Is there any scorpion bite or snake bite? The orthopedician will be arguing with you. Then you will get one. What is the Supreme Court judgment? MRI. And you have shown him there is an anterocerebral artery bleed. So doctor, frontal lobe, anterocerebral artery basically are the ones which are involved in lower limb monoparesis. That is the take home message. Posterior cerebral artery, it supplies midbrain, thalamus, lateral geniculate body and inferior and medial aspect of temporal lobe. So you must know individual vessels and their territories very clearly. Now if you take posterior cerebral artery, from there it is forming, basilar artery is dividing to form posterior cerebral artery. Now it is divided into two parts, P1, P2. P1 will supply midbrain, thalamus, subthalamic area. See, this is basilar artery, doctor. This becomes posterior cerebral artery. And posterior cerebral artery say those vessels which come inferior ramus, middle ramus, paramedian arteries and tuberothalamic artery, all these are basically called P1 segment. Whereas the medial posterior choroidal artery, lateral posterior choroidal artery, they are all basically coming from P2 and P3. So P2 syndrome में temporal lobe, occipital lobe signs will be there. P1 segment में midbrain, thalamus, subthalamic signs will be there. That's what you need to differentiate. Now what is delirium tremens? The withdrawal of the alcohol in a regular seasoned professional alcoholic will lead to the development of it. Then one of the options was ophthalmoplegia. So in which situation, in an alcoholic only you have ophthalmoplegia. Alcoholics are also vulnerable for thiamine deficiency. So Wernicke's encephalopathy can be there. And in that you will have the presence of the typical ophthalmoplegia. Now if you say delirium tremens, it is an acute alcohol withdrawal found in about less than 5% who are alcohol dependent, and it will occur within 72 to 96 hours after the stopping of the alcohol. As a house surgeon, when you are working, suddenly you will find a villager who is developing fits after 5th day of admission. You will be thinking, array, he is improving, I treated his malaria very well, why these seizures now? He is a regular alcoholic, 5 days he is abstained. What you are giving him is, hospital canteen say idli sambar. So where will that match the toddy? So he will get the rum fits, they are called as withdrawal fits, which is common in the past history of alcohol. So there will be visual hallucinations, tachycardia, hypertension with autonomic hyperactivity is what you typically come across. Now what are the triad of clinical features which you see in case of Wernicke's encephalopathy? Ophthalmoplegia, ataxia and confusion are the 3 features which constitute the Wernicke's encephalopathy. A 60-year-old is having progressive dementia with sharp biphasic waves. So now you know how important is the issue of EEG for the examiner. So All India 2011 question. So progressive dementia with irregular jerky movements which are myoclonus along with the periodic sharp biphasic waves. They suggest Creutzfeldt-Jakob syndrome. And in this you have progressive dementia with myoclonus with periodically synchronous biphasic or triphasic sharp wave complexes which are typical of Creutzfeldt-Jakob's disease. A 35-year-old female is having proximal weakness of the muscles with the ptosis and easy fatigability. How do you want to evaluate? Already we discussed myasthenia gravis. So if you look at the sensitivity and specificity, hydrophonium test is basically 95% sensitive and single fiber EMG is 99% sensitive. So you want to screen a person with a suspected diagnosis. If you want to screen the disease, sensitive test or specific test? First sensitive test so that you can detect, then specific test to confirm. Hydrophonium is basically highly sensitive with 85% sensitivity in ocular and 95% in systemic myasthenia. NARP syndrome is basically what? All India 2011 question. NARP means neuropathy, ataxia, retinitis pigmentosa. It is a maternally inherited mitochondrial disorder where patients have the combination of the peripheral neuropathy, ataxia, retinitis pigmentosa. How do you identify retinitis pigmentosa on this? There is bony spicule appearance, retinitis pigmentosa mein. So it is a mitochondrially inherited, matlab a mother can transmit to the children. The father cannot transmit. Why? Father donates sperm, mother donates ovum. Mitochondria is there in the cytoplasm of the ovum. So any defect in the mitochondrial DNA can only go through cytoplasm which goes through the ovum which comes from the mother. So that is the underlying reason. So identification of this mutation in the mitochondrial DNA is important for the diagnosis of the NARP syndrome is what we need to appreciate. So there are a set of neurological disorders which are mitochondrially inherited which you need to know. Kearney-Sayre syndrome and Pearson syndrome and MELAS, mitochondrial encephalopathy with lactic acidosis with stroke-like episodes, and Leber's hereditary optic neuropathy. They're all the examples of mitochondrially inherited disorders. Thymoma. What are the important associations with thymoma? So thymomas, which are anterior mediastinal tumors, what are the 4 T's you will remember in relation to anterior mediastinal tumors? T for teratoma, T for thymoma, T for retrosternal thyroid, and T for terrible lymphoma. The 4 T's in relation to anterior mediastinal masses. It can lead to the development of various paraneoplastic immunological syndromes like myasthenia. One more thing you need to know with relation to thymoma is pure red cell aplasia is also associated with the thymoma, is what you have to appreciate. In which condition do you want to use plasmapheresis? What do you do in plasmapheresis, doctor? Basically, you will take the serum of a patient, pass through a machine, purge out the antibodies from that plasma, and then once more give it back to the patient. So any antibody mediated disorder, autoantibody, you use the plasmapheresis. Myasthenia gravis you can use, Guillain-Barré syndrome you can use. If I leave to you a dirty list of conditions where plasmapheresis can be used is what need to be remembered. A patient has got ataxia, urinary incontinence and dementia. All India 2010 question. What is your diagnosis? Classical triad. It is a triad of what you call normal pressure hydrocephalus. In these people, what is the problem? The normal flow of the CSF on the cerebral convexities into the venous system. Basically, CSF is produced in the choroid plexus. And from fourth ventricle, third ventricle, second ventricle, first ventricle, you have got a drainage system. Finally, it becomes absorbed into arachnoid granulations. So the drainage of it ultimately into the veins is obstructed. But between one ventricle and other ventricle, there is no obstruction. Free flow is there. So that is a problem in normal pressure hydrocephalus. And in this, the CSF opening pressure, if you put a lumbar needle, then high opening pressure will be typically found. And if you do T2 weighted image, this kind of a dilated ventricle out of proportion to the sulcal atrophy. Elderly people also, because of the degeneration of the sulci, the ventricle may dilate. What is that called as? Hydrocephalus ex vacuo is the name which is being given. But in this, sulcal atrophy is not significant, but ventricular dilatation is significant, is one of the important features. Why you are worried whether sulcal atrophy is there or not? Because normal pressure hydrocephalus is commonly found in elderly people. And vascular dementia leading to atrophy of the brain, leading to sulcal atrophy is also found in elderly people. When they have a vascular dementia with a sulcal atrophy, they will also have dementia. Normal pressure hydrocephalus patients also will also have dementia. So, patient won't come with a stamp, I have normal pressure hydrocephalus, treat me. He will come with dementia. Then you take an MRI and you will be discussing in the neuroradiology, is it normal pressure hydrocephalus, is it vascular dementia? Then you will get up and say, no, there is a sulcal atrophy, hence vascular dementia. There is no sulcal atrophy but significant ventricular dilatation, it is normal pressure hydrocephalus. So, all of you are going to be another 8 to 10 months budding consultants in MD first year or MS first year. So, when you are preparing, prepare with that effacement that this is a transient phase, after finishing life is glorious, at least hope to be. So, doctor, this is a typical CT head where once more there is a dilated ventricle and the frontal horn of the ventricle, how it is rounded, frontal horn is a very, very classical feature of normal pressure hydrocephalus. Now if you take the CSF, the opening pressure of the CSF is high, but the protein, sugar, cell count, all the three will be normal. If they are abnormal, it is not normal pressure hydrocephalus, it is then what? A meningitis leading to hydrocephalus is what you will conclude. Then what are the clinical triad of features, doctor? Ataxia, urinary incontinence, dementia. But why ataxia? Because the normal pressure hydrocephalus is a dilatation of the ventricles. So you have a cerebro-ponto-cerebello fibers, cerebello-ponto-cerebral fibers. So cerebellum and pons, cerebral cortex के बीच में जो भी fibers जा रहे हैं, they are compressed and that is leading to ataxia. And your frontal lobe से जो fibers are coming and controlling bladder, they get compressed and urinary incontinence. But there is a misfiring of diagnosis a good number of times. Why? Any elderly person may have prostate hypertrophy because of that bladder problem. And he has got diabetes with some amount of dorsal column involvement and ataxia. And any elderly person will forgetfulness will be there. A simple normal elderly person ko bhi you may misdiagnose as normal pressure hydrocephalus. Similarly, meningitis with hydrocephalus you have to exclude. And you need to exclude vascular dementia with a sulcal atrophy leading to hydrocephalus also you have to exclude. And then consider normal pressure hydrocephalus as the diagnosis. Now a patient is having mitral stenosis and atrial fibrillation and acute onset of the left upper limb weakness is there completely within 2 weeks. Then what is the most likely possibility? So there would have been a cardioembolic shower because that fibrillating atria, and that is leading to the development of an ischemic stroke. And though he may have a complete recovery in the first few weeks after this shower of emboli leading to the acute insult, he may have the recurrence of the event unless you have intervened. And there is an entity called RIND, reversible ischemic neurological deficit. You know TIA, transient ischemic attack, stroke, and there is one more thing called RIND. So transient ischemic attack, when do you call it as? If there is a complete recovery less than 24 hours. Patient will say, doctor, I am having a little difficulty in swallowing fluids and my words are mumbling, but 26 घंटे के बाद अच्छा हो गया. The daughter-in-law will say, all acting business, कुछ भी नहीं है, सास जी को मैं दफ्तर से लीव भी लिया, 24 hours पे कम हो गया, मैंने सोचा कि बुड्ढी को कम से कम हाथ और पांव गिर जाएगा. What is this? Then you should tell, don't worry, daughter-in-law, this is called TIA. So you continue to not give aspirin, you continue to add salt in the food. Definitely the prognosis is good that your mother-in-law will get the full-fledged CBA. Take it as my word. Then you have a reversible ischemic neurological deficit. When do you call? Complete recovery is there, but after 24 hours, but less than 3. Now a 25-year-old person presents with acute onset of fever and focal seizures. On MRI there is a hyperintensity in the temporal lobe and frontal lobe with enhancement. Then what is your diagnosis? Many times we had this similar question. Classical. So on HSV encephalitis, the temporal lobe, lateral part of the temporal lobe. So enhancement of gadolinium flush on T2 weighted image is basically classical of HSV encephalitis, and they typically will have seizures, altered sensorium, fever, elderly person. Already we discussed now HSV encephalitis. It is a temporal lobe like this or inferior frontal lobe where the limbic system, cingulate gyrus is located, is the classical location. Most of the times it is unilateral, involvement is what you see, and if you take the gross section after death autopsy, then there is a hemorrhagic changes which will be seen in case of the HSV encephalitis. And this is once more, the medial temporal lobe, inferior frontal lobes which are showing hyperintensity on T2 and hypointensity on T1 weighted images is a very, very important classical feature. And in a patient who is having head injury, what can lead to the damage of the brain. So doctor, whenever we say head injury patient, it's an ongoing insult. Always remember, in casualty you are working. If you are trauma, most important thing that you need to give is administering the steroid. Dexamethasone shot dena hai. Diye to, those patients who received in the acute spinal shock stage mein dexamethasone, those who did not receive, there is a zameen asma farak in their ultimate outcome. So every minute counts. Then after a patient of head injury got admitted, how you managed him is important, because there are a lot of secondary factors which will promote the cerebral insult is what you need to basically remember.